And we're going to be starting somewhere in the middle of this patient's course in the ED for this simulation. It should be able to do basically everything. There are a couple things if you're going to be doing procedures, for example, just verbalize them instead of actually trying to do them, and then we'll kind of say, okay, but everything else we should be able to simulate. The other thing is the vital signs monitor. Some of the things are going to come through. You will not get end tidal and you will not get saturations on that. And so I will just verbalize those if those are changing at all. And then this is hooked up to, I believe, an artificial lung, right? So it's giving you numbers, but it may not work perfectly in that either. Thank you everybody for participating. I think it's going to be really helpful if we have a real scenario like the one we're about to go through today. Does anybody have any questions at least before Dr. Drews gets here?
I'm Frank Casey. I think I know a lot of you. So I'm the Pediatric ECMO Medical Director. I want to orient everyone to this new fancy sign that we'll have up in our PEDS ER, in our adult trauma ER, just for cases like this. So if we ever have one that is either active CPR in a child or a patient that is really sick and might require ECMO, excuse me, all we have to do is call this number to get a hold of the cardiac intensivist on. We'll screen, if you call this number, you'll get a hold of the attending on. We're always in-house. So we'll screen if the patient's a candidate and then assist with sending out the page if we're going to activate. We never do ECMO in the ER here, so the patients for all ECMO. The only places we cannulate are the pediatric cardiac ICU, the OR, and the cath lab, I guess, too. So all their patients have to be transported back, which is part of why we're kind of going through this whole thing. So I'll just be standing in the back. Andrew's going to run it here, and then he'll go through debriefing at the end too as well. But before we start, any questions at all about how we're going to go through? So it's starting mid-case, so he'll talk about kind of where we are in this transport, so we can focus on the things that are most important for this case specifically.
50-kilo male who was a restrained passenger in a high-speed MBC on I-68. Airbags did deploy. The driver was found dead at the scene. EMS arrived shortly after. He initially had a GCS of 14 for confusion, but otherwise was alert, able to answer most questions. He was complaining of chest pain and difficulty breathing and was in moderate distress. His initial vitals, he was afebrile, heart rate of 114, respiratory rate of 32, BP 108/60, satting 82% on room air. He had generalized small cuts, but no major external area of bleeding. He had bruising on his chest wall bilaterally. He was tachycardic, normal rhythm, no murmurs, rubs, gallops, strong pulses, good cap refill. He was tachypnic to the low 30s. He was in moderate distress. And then he had coarse breath sounds bilaterally, but no wheezing. And the remainder of this exam was not significant. Placed the C-collar, initially was on the non-rebreather, which temporarily brought his sats up to 96%. But by the time he was arriving to the ED, he began to desaturate again with worsened distress and satting 78%. Due to the respiratory distress and desaturations, he did get intubated upon arrival to the emergency room, and the remainder of his primary survey was intact. He had normal circulation, and now with a stable airway, his breathing was improved and his saturations were up to 94%. The secondary survey, again, revealed the bruising on the chest wall bilaterally and the scattered abrasions, but otherwise unremarkable. We sent him for scans. His x-ray showed his ET tube was in good position in the mid-trachea. There was no pneumothorax nor effusions. There were bilateral fluffy infiltrates consistent with pulmonary contusions, right worse than the left. No pelvic fractures, and then we pan-scanned him as well. CT head showed a small right-sided occipital subdural, but nothing else, no midline shift. CT chest reconfirmed the pulmonary contusions, didn't show any evidence of aortic dissection or other thoracic trauma, and there was no intra-abdominal pathology either. Upon his labs returned relatively unremarkable. His H&H was 12 and 36, platelets 250. He doesn't have a white count. All of his lights are stable. His glucose is 120. His LFTs are unremarkable. His coags, his PT is 18, PTT 42, INR 1.4. You initially sent the BBG. The pH was 728. PCO2 was 50. bicarb of 20 with a base deficit of 4, lactate of 3.2. The ICAL on that is 1.2, and sent a type and screen. So we are going to start this scenario with him returning from CT scan.
Do we need to?
Yeah.
Just sort of the vitals.
You guys told us it's a P1 trauma, so
So his
back
repeat
here,
vitals, his heart rate,
there, so
yeah,
I can go
is
into
105,
Sure, everybody show up.
4
Yes,
over
please.
60.
Okay, we're gonna go back to work.
However, his saturations are dropping to 76%.
So let's reconfirm our individuals using space and troubleshoot our vents.
So there would be chest X-ray, we'll listen to lung sounds here.
You do have present and title, it's reading 55.
And could we at respiratory just check that the vent's set up and everything looks okay on the vent?
It is.
Of course, breath
Let's
sounds.
do the higher two currently.
100%. Desetting on that. Do we have any pneumothoraces on our repeat chest X-ray?
No, so if you get a repeat X-ray, there's no pneumothorax, no infusion. ET tube shows that it's in an appropriate position. The opacity is looking a little worse.
Worsening pulmonary contusions, worsening hypoxia on the vents. Our tube is in the right place, we have no pneumothoraces.
We've checked the vent.
We could increase some of our positive pressure, see if that improves our oxygenation, increase our heat as much as we're allowed to.
Your saturations are continuing to drop. Now you are satting into the 40s.
The 40s,
Yeah.
okay.
So we probably should take them out.
Yeah.
I mean, we need to talk to thoracic surgery, whoever covers pathology, like trauma research and pediatric.
So then go ahead, I would go ahead and double them.
Yeah, so we
Send
call
them.
that number.
So we can call, you can call someone on there now.
Okay.
Yeah.
Okay,
You'll get an extra call.
Zach, can I have my phone back?
Jared, you can call too. You need your phone.
It's here, he's bagging and he's helping, I can help.
1, 3, 3, 2, 1, 9. I think I just for you.
Are you good? Okay.
Yeah.
Your saturations are not improving. It's still in the 40s.
Hey there, this is Jared. I'm a pediatric ECMO consideration.
And is our heart rate
Normal one.
Your heart rate is reading accurate.
We're getting very started, we have some afternoon available.
Yeah, it's actually running GCS 14, for stress. Was intubated on the
What's our repeat blood pressure, do we have a pulse?
involving
We do the atrophy.
contusions and then with the X-ray. He now has refractory.
Other
He's
options,
been
yeah.
actually at 60s.
I don't feel great pulses, they're
Initially it was normal intensive, heart is now becoming 30 to the 40s.
We're getting ready to take our blood pressure.
And we're about ready to start
I don't feel
compressions. We are providing.
I also provided pulses.
Yeah.
We start CPR,
Yeah.
we give our atropine.
Yep.
He does have a severe subthermal trauma. He has had CT,
Yes, we can do that too.
thoracic or for abdominal bleeding. Compressions have just been started.
1 milligram of epi given.
14 years old. Okay.
You want to grab that?
Oh, yeah.
I'm working with this with compression with someone, and who's
Yeah.
next in line to do compression?
Any specifics, anything?
Can you say what you
We'll
tag
take
out?
them out when we want.
Okay.
Yeah. Okay, appreciate your help. Alright, so they will be activating our ECMO team. We'll prepare for transport. We'll bring the coach tray with us as we continue compressions on our way to the OR.
Did they say a time frame?
He's activated now, basically.
Are they letting my OR now?
Yes, he's letting cardiac, OR, everyone else know on his end.
Is someone ready to switch?
Are you ready
Yeah,
to
I'm
switch? Yes, we'll do.
Rhythm check.
Oh, sorry. It's okay. I heard you were like,
Can someone keep track of time?
What?
Just don't know what time was.
Okay.
we haven't been titled concussions.
Yes, 3:15.
You let us know when we're due for an RFP.
What? Still a little minute before I. Pulse check.
We assign a staff.
I don't feel pulses.
All right, PEA, continue professionals.
Just a little bit. Ready? Yep.
What do we do for our next RFP?
Right now.
1 milligram of epi given IV. Jared, you want any other drugs? Do you want any other drugs?
Let some have him like packaged so that as soon as they're ready to take him, or can like have him ready to go. As far as monitoring stuff.
Well, put the juice over. You ready for a pulse check?
We have 20 seconds.
20 seconds.
Or he'll be. We'll do a pulse check and if you will,
Just have one.
whenever you need to switch out.
Ready? Yes.
Pulse check.
I still don't go pulse.
Pulse check.
No pulse.
So PEA.
Still PEA in the monitor.
Oh, what the CPR.
Yeah, because it's like,
It's just hard, yeah,
Yeah.
just imagine it with
that's
that.
what I was thinking in one.
Yeah, we do have in some places, yeah.
Okay, so bilateral infusion, back for national PDA or as given after we'll get our next dose, we would do in the next 2 minutes.
Yeah.
What are the acting teams, are they gonna call you back when they're ready for us to transport over, or what's the?
He,
The plan.
I can call him back, he said he was activating everyone on his end, but I can call him back and make sure.
Yeah,
we're not on
it's gonna take time to get out of there, so we just want to. When we start rolling, we can probably do the job.
We are still in PD.
We have to do that.
Let me go grab it.
Okay.
I mean, I'm not exactly sure, so it's adult size, so he's 50 kilos.
Okay, to the south. Okay. All right, he's entering the meeting now, already, he's gonna take one hand off on us and then transport. Hey, you're good for another epi.
Okay.
Also pulse check. Pulse check.
I do not feel pulse.
What's on the monitors?
It's PDA 17.
So,
Sorry, man.
1 milligram of epinephrine given?
Or the gentleman who talked about working 7 miles per hour and was initially responsive with fracture bilateral pulmonary contusions, needs to be on battle for respiratory distress, basically between 60 and 40 Has been gotten clear on the epi, continuing concussions, remains at again has that subdural, occipital subdural on his 60 and otherwise
are we ready for the transport? Are we ready for the Lucas? Okay.
Just to make it easier. Continue
All right, so-
transport.
I'm good. I'll take over from here for the CPR and for the transport.
Are you okay with the Lucas and the transport?
Yeah.
We're just switching methods.
I have one more minute and full pulse check.
So with the next pulse check, we're gonna roll him, I'll hold these kinds of cautions. He's gonna put the board under him and then we'll attach the Lucas.
And you will go with us for disconnecting the Lucas?
Yeah, we can do that,
Yeah.
yeah.
There will be someone to, we don't operate that.
Yeah.
Okay, we ready? I don't want to delay getting back now. 1, 2, 3.
Board's under?
Let's do the first check.
I do not feel pulse.
Or let's continue. What's the rhythm?
It is 65, Y complex.
Okay, all right. We'll continue. And when it's time to give the epidose, we'll give the dose. Okay, does anyone need to do anything before he gets transported? Alright, so Jamie will help with the bagging. Are we going to OR or the CIC? We'll go to the CIC. So, do we have the transport medication ready? Yeah, I have the calcium bicarb. Okay, perfect. And who's gonna move? Who's gonna go with us? We need a nurse for documentation and a nurse for medication. Okay.
I'm going to.
You're going to? Okay.
Also do for another epi.
All right, let's get the dose of epi before we walk.
Are you documenting? Alright. Are you actually? Yeah. Alex is coming.
So we turn to the right.
Good. I'm great.
Look like a turtle. Oh, thanks. I didn't know to carry you. Look like a ninja turtle.
Yeah, yeah.
side. We'll continue to keep
No, it is. It's on here.
Is it helpful that people are serious?
No, ma'am, it's not.
I can drive this bad. It's
Yeah, it's
easier
easier
for
for
one
one
person. I got you.
I was gonna try to do this.
Yeah. Oh, it's not real.
down. Alright, so we have the transport elevators down, so we have elevators on this side. The one next to
Last 20 minutes.
Can you guys do a space, please?
We need to all get on there. Thank you.
Thank you.
Get off here.
And
Would you bring other happy? Would you
Oh, yeah, let's go ahead and begin the happy.
Sorry. Thank you.
You guys can take the stairs. There are stairs here.
Well, they have a stretcher too.
Oh, they are stairs too?
Alright, thanks.
Oh, I thought they were part of our team.
No, it's part of our team.
Oh, okay.
Yeah. For the equipment.
Alright.
It's not on stairs, so it's easy to get out. Yeah, we have to grab that hand out. It's getting sweaty. Alright. Oh, you're good. You're good. I got this. When it's on here, we're good.
We'll go to bed 17. On the right, yeah. We'll go turn to the right side.
Go down. Hold on, hold on.
Probably move into the bed, to the bed slowly. Put it back on.
I think we're just.
Does somebody have to? One, two, three.
That's way over.
Is it time for the next dose of therapy?
Yeah, would you like it now?
Yeah, that's
Okay.
I think, can we stop this for a minute, just check for the pulse? And rhythm. There's no pulse. What's the rhythm? Okay, we have pulseless electrical activity, so we'll continue.
Yeah, my favorite is
So we have a 14 years old patient.
Oh,
with
I'll
a
switch it.
heart
Yeah.
and developed ARDS, got eventually cardiac arrest. We are doing CPR for almost now
19 minutes.
19 minutes. So I think he doesn't have any other major trauma except for a small subdural bleed on the right side. He's not actually bleeding from anywhere. The imaging is negative. Otherwise, for any intra-abdominal or any other trauma. So I think it's primarily a respiratory.
Okay. And you see all out of the year.
So we don't have a.
If we cleared the seats.
We have camera. I think we have CPC spine.
We have the CT spine is negative.
We would still leave it on though until we got an MRI. Unless we're gonna paralyze.
He's cardiac arrest, he's not moving.
situation
with a negative CT spine.
You have a PEA, so you should go on the ECMO. He's 50 years old. We just told you they could look at the ultrasound if he wants vessels are adequate. And what size drawing cannula do we need for this patient?
It would be a 15 and a 23.
Okay, and they get the percutaneous dilator case ready. We'll just take a look at the drawing. Okay, it seems like a with the super percutaneous VA acting for the drawing. Alright, you guys open the stuff and we'll get ready.
All right, perfect.
Steps. Exceptional care, better health.